And since we have your information and your email contact, we'll make sure to send that out to everybody. So with that, I want to go ahead and provide a little bit of an introduction to your panelists today. So my name, as I said, is Alice Buffkin, and I am the Director of Policy for Child and Adolescent Health with Citizens Committee for Children, and I'm also here with my colleague, Sophia.
Good afternoon, everybody. My name is Sophia Halkitis, and I'm a data analyst here at CCC. And with that, I'm just going to give you all a brief introduction to Citizens Committee for Children of New York. So for those of you new to CCC, we've been around since 1944, working to make New York City a better place for children and families. Our mission is to see every New York City child healthy, housed, educated, and safe. And we do this a few ways. One of them is through city and state policy advocacy. We also have a large research and data component of our work, including data-driven publications that can be used for advocacy, and our online database, data.cccnewyork.org, which will be the focus of our webinar today. We also host civic engagement programs to engage and educate youth and adults alike to do advocacy at the city and state level.
So before we dive in, we wanted to give you just a brief overview of the webinar's content and its purpose. So Sophia is going to start by providing you with an overview of CCC's Keeping Track online database, which will provide some sort of an overview of the array of different data indicators that CCC tracks related to healthcare. She'll provide an overview of how to access and interpret this data, and we hope that it will be helpful to your work. Then we'll touch on a few specific data trends and use those data points to draw out a few key policy issues of interest. At the end, as I said, we'll have an opportunity for questions.
Great, so I'm going to get started and talk a little bit about our online database, data.cccnewyork.org, also known as Keeping Track Online. This database is actually the largest municipal database on family and child well-being in New York City, and it features hundreds of indicators and breakdowns. This website hosts a number of data that are directly related to child health, which includes vital statistics data, like things on births and deaths, as well as health insurance data, environmental factors such as asthma, and alongside data on a slew of other demographic and social determinant factors such as education, economic security, and neighborhood conditions. So this is what our homepage looks like. You'll see that I have a box around the Explore Data feature. This is the feature that I will be talking through some of the data points through today. So that's why I have a box around there. And I'm just gonna start to walk through some of the sources of data, health data on Keeping Track Online. So here on the left, you'll see that we have a number of indicators on health. And as Alice mentioned, we won't be able to go through all of our health data today, but we do encourage you all to check it out. The health data on data.ccc New York comes from city, state, and federal sources, meaning that they come from different agencies, they have different years of recency, and they're released on different geographic levels. So in some cases, you might see community district, and in some cases, you might see United Health Fund district. But city data do make up the majority of the data in this section, coming from the Department of Mental Health and Hygiene. This includes the vital statistics data about births and deaths, and it also includes data on asthma and environmental factors such as blood lead levels and walking distance to a park. Most of these data are up to date for 2017. We also have a host of federal data coming from the US Census Bureau's American Community Survey, which provides estimates of things like insurance information, disability status, Medicaid status, among others. And in those cases, 2018 will be the latest data. And these data are used to inform our advocacy on the things that we've mentioned, and they're also available for folks like you all to use in your grants, in your program planning, or if you just want to browse the data on your own community. So now I'm going to hand it over to Alice to remind you all of an important framework as we talk about health today.
So thanks, Sophia. So before we move into the data that Sophia is going to discuss, I wanted to lay out a brief framework to keep in mind as we discuss this data and hopefully to use as you review CCC's data sources in your own time. So this is a concept called social determinants of health, which I'm sure many on this webinar are already deeply familiar with. It's really been growing in popularity amongst health stakeholders in recent years. Broadly, it's the idea that the conditions in which people live, learn, work, and play affect a wide range of health risks and outcomes. In essence, it's an attempt to recognize that only a fraction of health outcomes are determined by medical care. The majority of health outcomes are instead determined by environmental, social, economic factors. So for a lot of folks, this may seem pretty intuitive, and you may already work extensively with this framework in mind, but it's only in the last few years that it's gained sort of a broader traction. This slide here is pulled from Kaiser, and it provides a breakdown of some of the social determinants of health. So things like economic stability, neighborhood environment, education, food insecurity, all of these things impact health. It's not appropriate or really helpful to focus exclusively on individual circumstances and behaviors without addressing the systemic issues that influence health. But while this chart is really helpful, I want to pull back a little and look at a more expansive model that positions social determinants of health amid broader socioeconomic and historical context, one that really looks at the roots and contributors to social determinants of health. You can see in this model up here that we do need to step back even further, away from things like transportation and food insecurity, to think about what are the historical and systemic causes, including things like institutional racism, class oppression, gender discrimination, that have led to the systems and policies which themselves create specific social determinants of health. So a lot of folks kind of narrow in on that social determinants of health without stepping back a little and thinking about, well, what actually leads to those disparities that we see in those areas. So this is a presentation that is largely about sort of some of our health data indicators, how to use these, some of the trends that we're seeing, some of the policy issues. So we're not really, able to in this presentation really do a deep dive into some of these issues around social determinants of health and its framing. But we did at least want to start off with this framework to put it into your minds and to think about the broad array of factors from housing policy to social safety net services to education systems that contribute to the health outcomes for children in New York and elsewhere. So now I'm going to, in a moment, turn it back over to Sophia, who's going to discuss some key data trends in children's health. So again, given the limited time we have in today's presentation, it's not our intention to go through all of the health data indicators on CCC's website, in part because we know that you all may be interested in doing that on your own. But we do want to touch on a few select data points and child health trends that may be of particular interest, either because they're new to sort of the data CCC is providing, because they've been in the news recently, because there's been recent trends that are of interest. But we really encourage you to explore other KTO indicators at your leisure. So I'll go ahead and turn it over to Sophia.
Great, thank you so much, Alice. So here, as I've showed you all in the previous slide, this is the homepage of our website, data.cccnewyork.org, or also known as Keeping Track Online. And again, I'm going to be going through this Explore Data tab. So before we even get into the health data, I really want to show you the wealth of data that we have on the site. We have topics such as demographic factors, early education and care, economic conditions, education, housing and homelessness, youth and juvenile justice, health and mental health, child welfare and community safety. So all of these indicators are in many cases actually available also by race, ethnicity, and by age group. But I'm gonna really hone in to talk about right now uninsured rates, or rather health insurance coverage. This is one of the federal data sources coming from the American Community Survey. And we just wanted to be sure to talk about health insurance coverage because it is such an important factor in making sure that kids are healthy, which again is one of the pillar stones of our mission. So before I really dig into the trends, I do want to give folks the opportunity to become familiar with the interface of data.ccc New York so that they can browse the indicators themselves with ease. So here is the page that you'll see when you load any indicator on the site. There is a map view of the data itself. There's a trend line to the right of the map and a table that populates with the data for New York City. On top of the map, there's a series of options that allow you to customize what is represented on the map. So right now, the map shows the number of folks that are uninsured of all ages, as we can see in the legend. However, we're able to toggle this so that the map populates with data for children under 19 or adults 19 and older. Additionally, we can change the location view on the map. Right now, we're looking at the community district map, which is the most common geographical breakdown on our site. But we may also decide to view these data by borough or by city. And I'm going to flip back to community district. We also might want to see the percentage of folks that are uninsured rather than the number, as this can be more reflective of the general population. So that functionality is available on Keeping Track Online, and the table on the right side of the map will also populate with the data type you've selected. And last, you can change the map view to any previous years of data. Most data years do go back to at least 2008, but in many cases go back to as early as 2000. And so this trend line and all the data, the map, and et cetera, will populate based on this year that you've selected. So I just wanted to give the opportunity to go over this stuff. I also should mention that our source information, definitions, and any relevant notes can be found at the bottom of the map. So if folks were wondering, how is this defined, or what's the source, that is where it's always will be found. So now, I'm actually just gonna start talking through some of these trends and looking at uninsured rates at large, specifically for children under the age of 19. So there's been a decline in uninsured rates over the past decade in New York City, in New York State, and the United States at large. However, New York City actually has the lowest uninsured rates for children of all of these entities. In New York City, the percentage of uninsured children has decreased from 5.7% in 2008 to 2.5% 10 years later in 2018. This is a really excellent decrease in trends that we see, but unfortunately, there are still some neighborhoods with higher uninsured rates than others. Flushing and Bayside here are the two dark gradient neighborhoods on the map, and they're two adjacent neighborhoods that had the highest uninsured rates for children in the city in 2018, at 6.6 and 9% respectively, more than triple this citywide average. I also just want to flag while we're here, which is not visible on the chart, that more than 50% of New York City children are covered by Medicaid or CHIP, which is also viewable in our health data. And it's also important to note that even when child uninsured rates are low, we do have pockets of areas where uninsured rates are still quite high for adults. This is the case in Sunset Park, where children have an uninsured rate of 1.1%, which is much lower than the citywide average. But adults have an uninsured rate of 15.5%, almost double the citywide average for adults. I'm going to hand it over to Alice to discuss some of the drivers behind these trends that we see and other policy considerations.
Thanks, Sophia. So, New York has one of the lowest uninsured rates in the country, and that's not a coincidence. We've gone from, as a state, having 17% of children uninsured in the late 90s to only 2.5%. And we're one of only a handful of states with an uninsured rate this low. And we got this way through a combination of different policies, including offering broader Medicaid eligibility than many states and engaging in extensive outreach efforts. So that really just underscores that there are policy efforts that can be made to improve coverage among an array of other health outcomes. When we discuss policies designed to increase coverage for kids, an important issue to keep in mind is something called the welcome mat effect, which has shown that increasing the number of parents who access health coverage ultimately increases the likelihood of children being insured and ultimately having better health outcomes. So this is why it's so important to maintain and expand coverage options for adults, and why it's so concerning when we see these rates decline. Sophia spoke to some of the fairly striking disparities we have in uninsured rates in parts of the city, with areas like Elmhurst and Corona experiencing particularly high uninsured rates for both children and adults. These also happen to be areas with higher rates of immigrant New Yorkers in them. And this brings us to an important issue to address, which is a broad range of policies the Trump administration has pushed that have really created barriers to health coverage. So one federal proposal you may have heard about in recent months is something called the public charge rule. This is a rule that, if implemented, would have fundamentally shifted the country's approach to legal immigration, making it a lot harder for low-income immigrants to obtain a green card. The rule change would have substantially broadened the types of public assistance that would count negatively against an application for legal permanent residency, which is also known as green card status. Immigrants who receive food assistance through the SNAP program, healthcare through Medicaid, or federal housing assistance for certain lengths of time would have been at a significantly greater disadvantage, greater risk of being ruled a public charge, and as a result could have had their green card applications rejected. So an important thing to say immediately is that while this rule was supposed to go into effect on October 15th, federal judges in New York and several other states issued a nationwide injunction which temporarily blocked the rule. And that was really the result of a lot of national effort, including here in New York, to really find every avenue to try to stop this harmful rule. Even if this rule had gone to effect and we're still there's still many steps to litigation, so it's temporarily blocked, but we will need to continue to keep an eye on what happens next. It's important to know that the rule who the rule wouldn't have impacted. So it wouldn't have impacted citizens, only those applying for entry into the US or a green card. There are a large number of immigrants who are exempted, including asylees and refugees, and use of benefits by children and family members would not impact an individual's application. But despite all this, the fear and confusion about the public charge has been widespread, and it's been impacting immigrant communities for months, ever since the proposal was first rumored over a year ago. In New York and across the country, we've seen the impact of what's known as the chilling effect, where individuals have disenrolled from critical services, even if those individuals wouldn't be impacted by the public charge rule, and even if the programs they were using wouldn't be covered by the rule either. In New York, for instance, we've seen families choosing to stop using WIC services. We've seen concrete research showing more and more immigrants have stopped using SNAP benefits. We've heard anecdotes of people who've opted not to use life-saving services like cancer treatments out of fear that it would impact their immigration status. So going back to the data Sophia covered on uninsured rates, we can see how something like the public charge could impact health coverage. A new study from Kaiser Family Foundation found that nearly half of community health centers report that patients declined to enroll themselves in Medicaid last year, and that's a national statistic. Nationwide, there's been an increase of 400,000 uninsured children in the past year, reversing decades of progress. Now, New York is one of the states that has not seen that decline in ways that other states have, and again, that's a testament to a lot of robust policies in place to try to keep those trends from slipping. Though there are a host of factors that might be contributing to these declines, we know that one of those factors that's often cited is anti-immigrant policies like the public charge rule. So again, I want to iterate that the rule is currently blocked, but much of that fear has already had the intended impact of chilling the use of benefits. So something we here in New York City need to do, especially if anyone is working directly with immigrant communities, is let your communities know that they don't need to fear accessing services, and they should in no circumstance disenroll their children from services. We still have a lot of work to do to dispel misinformation and to make sure families are accessing health and social services they need, as well as the legal services they might need. And as a city, as a state, we need to continue protecting and expanding services available to vulnerable communities to counter the impact of these types of proposals. So if you're interested in keeping up with what's going on with the public charge, I really encourage you to sign up for Protecting Immigrant Families down there on the bottom. If you Google it, you'll be able to pull up their website and sign up for updates. So with that, I want to turn it over to Sophia, who's going to talk about another data point of interest.
Great, thank you, Alice. So I'm going to move along here. As we said when we began, our intention is really not to go over all of the health data that's on our site. Instead, we want to provide you all with a sample of data that are either newer to the site or particularly salient issues in the news. So I'm going to go over life expectancy, which is one of the newer indicators that we've added to the site that we thought would be of particular interest. Life expectancy is reflective of so many other factors, including poverty, housing, and healthcare. Life expectancy could be defined as a statistical measure of the average time that a person is expected to live based on their year of birth and other demographic factors. So I'm just going to scroll down to the map here and let folks take it in and see if, see the trends themselves. So in this case, the numbers on the map are actually representing years, not not percentages or rates or anything. So we see in the places where there is yellow on the map are places where there's a higher life expectancy, and places where the darker colors are on the map are places where there's a lower life expectancy. So first and most noteworthy, we have an 11-year gap between the Upper East Side and Brownsville, Brooklyn, where the Upper East Side has a life expectancy of 86 years and Brownsville, Brooklyn has a life expectancy of about 75 years. Another trend that's very salient in this is that in the Bronx, up here, about 3/4 of the neighborhoods had a lower average life expectancy than the citywide average, which again is 81.2 years. I'm gonna show you all some available breakdowns that we have on this indicator. On uninsured, we only had age group, but here on life expectancy, we can actually view the trends by gender for the city only. So here we can see that for females and males, there is a different life expectancy. I'm sorry, I'm having a glitch with the site for a second. There we are with the table. We can see that there's a difference in life expectancy for females and males, such that females have a higher life expectancy than men, and this is consistent with nationwide trends. I'm also going to scroll along to race ethnicity, where we see that Hispanic residents have the highest life expectancy relative to their white and Black counterparts. It's worth noting that the high life expectancy in some neighborhoods that we saw, including Elmhurst and Corona, including Washington Heights, might be driven by the large portion of Hispanic residents that live there, as viewable by this race data. And I also want to note here that race data was not, that life expectancy data was not available for Asian and Pacific Island residents because of limitations in the data on producing reliable estimates. So I'm going to go along to the bar chart view so that we can see a different view of these data. On neighborhood poverty, in the bar chart view, you're able to compare in a way that you're unable to do on the other views. So here we have neighborhood poverty, which can be defined as the percentage of respondents with incomes below 100% of the federal poverty level, where very high is about 30% or more residents are living 100% below the federal poverty line, and low means that there's less than 10%. And again, in case you're not memorizing these definitions as I go through, the definitions can always be found underneath the chart. And so here we can really see that life expectancy increases as neighborhood poverty decreases. And I'm going to turn it over to Alice to talk about some of these trends and the implications of them.
Sure. Thanks, Sophia. So as Sophia mentioned, one of the reasons life expectancy is such a compelling and important data point is because it often serves as a summary measure of a whole host of factors that impact health outcomes across the life course. So we know many of the immediate drivers of low life expectancy include health conditions and behaviors like diabetes and tobacco use. We also know that nationwide, we've seen a decline in overall life expectancy in the past several years. Some of that decline has been attributed to increased drug overdoses and suicides. These issues point to the importance of investments and interventions that target mental health, substance use, access to healthcare, and economic security. As Sophia pointed out, we also know that when you live and grow, where you live and grow up can impact your health and your life expectancy. A recent study actually looked at the 50 largest cities in the US, and it found that New York has the third largest life expectancy gap between neighborhoods. And cities with the greatest variance are also places where racial and ethnic lines between neighborhoods are most stark. So Sophia already spoke about the significant role that poverty concentration plays in life expectancy. We know that these income disparities in turn often correlate with ethnic and racial disparities in cities. Poorer communities of color tend to experience less investment from businesses, struggling schools, lower wage jobs, environmental risk factors, challenges in accessing adequate housing. All of these issues contribute to poor health outcomes and disparities. And in turn, we know that these disparities in investment and resources are a legacy of historic and often racist discriminatory policies and systems like redlining that continue to have a long-lasting impact on communities of color. So we wanted to touch briefly on these issues to make the point that life expectancy indicator doesn't exist in isolation. It's impacted by a host of other social, environmental, and economic factors which have their own policy levers to try to improve outcomes. CCC has long recognized that improving child health and well-being requires advocacy not just around healthcare, but also around advocacy for housing and homelessness, food insecurity, childcare, child welfare, a whole host of other intersecting issues that impact children and families every day. So we hope that the data we track will also help you make those connections, which I know many on this webinar are already making every day in the work that they do. So now I'm going to turn it back to Sophia, who's going to discuss a particular issue related to environmental and population health.
Great, thanks, Alice. So I'm going to navigate back here to our all indicator view. And I am just going to make a quick reference to the fact that we have a bunch of other public health data here, including asthma and walking distance to a park. But the indicator that I want to cover now is children under 6 with elevated blood lead levels. This is an issue that's been widely publicized over the past few years. Particularly, there's been a lot of public attention on lead poisoning in NYCHA housing. However, blood lead levels and blood lead poisoning is not an issue that's unique to NYCHA housing. The main source of lead poisoning is living or going to school in old buildings where lead paint was used, among other things. This is a great example of an issue that CCC has been monitoring the data to inform advocacy around lead. And just to put this in context, lead exposure has lifelong cognitive and behavioral consequences on children. This is including an impact in cognition. Lead poisoning causes developmental delays, learning difficulties, weight loss, vomiting, hearing loss, seizures, and a host of other side effects. So I just wanted to give that context as we go through these data here. So first, I, of course, want to scroll to the bottom to show you the definition of the data that we'll be viewing. Elevated blood lead levels are defined as the number of children less than 6 years old who were tested for blood lead levels that exceeded 5 milligrams per deciliter. And the rate that we'll be looking at is calculated by the rate per 1,000 children tested. So to dive right into here, we can see that some of the most darkest gradients are actually taking place in Brooklyn. As a matter of fact, Brooklyn makes up about half, particularly 47% of all the children under 6 with elevated blood lead levels greater than 5. Another quarter of these children is made up in Queens communities. So some important things to point out are the districts with the highest rates. So I'm going to switch to the rates here, and we can see that Greenpoint, Brooklyn has a rate of 45.4 children testing positive per 1,000. And another neighborhood of the highest elevated blood lead level rates is Borough Park with 32.5. Rates higher than the citywide average do tend to cluster here in Brooklyn, as well as the northern parts of Staten Island in Stapleton, St. George, and in Port Richmond. But I want to show you all the data in their table view, which allows you to see all the data points at one time, unique to the bar chart or the map view. So here I'm going to look at all the communities, and I'm going to use these arrows to sort the data in order of least to greatest. And here we can see that the lowest rate of elevated blood lead levels for children was in Lower Manhattan at 3.3 children per 1,000. And as we scroll through all the communities, we can see that this incrementally grows quite a bit to when we get to 45.4 in Greenpoint, which is the #1 highest rate. I'm also going to flip to the number view just to give you all some context and some scope as to how many children this is affecting in New York City, at least in 2017. And that is about 4,000 children in total. So I'm just going to pass it over to Alice to discuss some lead advocacy that CCC has been involved in so far.
Thank you, Sophia. So there are a number of different sources of lead poisoning, as Sophia pointed out, but the most common does come from deteriorating paint that has lead in it. And unfortunately, New York City has a lot of old housing stock, which is more likely to have dangerous lead paint. Sophia's discussion of geographic disparities points to both the possible concentration of lead in certain older buildings and specific neighborhoods, but also provides an indication of where adequate prevention and remediation efforts are and aren't taking place. I will say the city has made some really important and impressive strides in reducing lead poisoning in children. And a lot of this occurred after the city passed an important law in 2004 that's known as Local Law 1. It included a number of measures to reduce lead poisoning. Since then, there's been an 89% decline in lead poisoning cases, but we're still obviously a very long way away from the original goal of total eradication by 2010, which we are quite a ways beyond. As you may know, the comptroller actually recently released a report that in part stated what a lot of advocates have been saying for a long time, which is that the city needs to be doing more to reduce lead poisoning in children. Local Law 1 included a number of requirements for landlords, including that they need to do an annual inspection and an inspection and abatement when a housing unit turns over. Unfortunately, we know that time and time again, these requirements are not being followed and kids are getting poisoned as a result. And we know that the law that's on the books is not being enforced. We can see that in the fact that the Housing and Preservation Department, which is responsible for issuing violations of things like not doing lead abatement, they issued 0 violations for a building owner's failure to comply with turnover requirements or to perform mandated annual inspections, even when we know these violations are occurring. So these violations are occurring, therefore we should have a record of them being cited, and we just don't have that. So clearly our city needs to strengthen enforcement measures for landlords and take more proactive approaches to lead poisoning prevention. So we're not just reacting after a child shows up in a health department with a case of elevated blood lead levels, and then they go back and they see what's happening in that source. We need to be more proactive. We need to make sure kids are not being poisoned at home. We also need to protect existing public health funding. An issue that's gotten relatively limited media attention is that New York State actually cut millions of funding for New York City's public health infrastructure last year. And that covers a wide array of services, from home visiting to lead inspection, to HIV work, to a whole host of school-based services, really sort of the infrastructure within New York City. Many pieces of it saw a cut as a result of this New York State cut. The only reason that programs didn't experience cuts was because the city council and the city stepped in to replace that state funding. So especially in light of federal threats to healthcare broadly, it's important for the city and the state to continue to support public health efforts. And there are a number of different approaches to reducing the risk of lead poisoning. And we hope that data like this, which shows where the geographic disparities are and how trends have changed over time, can be a really important piece for determining where really increased efforts need to take place in improving health outcomes. So in a minute, I'm going to turn over to Sophia, who's going to talk about an issue CCC has been working on that really kind of impacts all of these issues across the board.
Great, thank you, Alice. So I'm going to move into talking about the census. So this is super important because when we talk about data and the federal programs that are supporting the health and the longevity of children and families, it's really important to consider those resources in relation to their funding stream, which is the decennial census population counts. Many of you are likely familiar with the decennial census, which will be taking place again in 2020. However, what's less well known is how those forms and data are ultimately used, which is funding and congressional reapportionment. Census data are responsible for divvying up billions of federal dollars to go to states with the highest needs. In fiscal year 2016, New York State received more than $73 billion in federal dollars for programs including those you see on the screen, like SNAP, Medicaid, Head Start, the National School Lunch Program, and also Section 8, and the list really goes on. Census data are also responsible for apportioning the congressional seats among the 50 states. New York State has lost 2 congressional seats in every census since 1940. That means that there's less people representing the interests and the needs of New Yorkers in Congress. So the difficulty about this is that there are undercounts on the census. That means that some people don't respond to their census form, and then there is inaccurate information about how many people live in a place, in a geography. So this means that it leads to less funding that's available to support the true population that live in that place. Of particular concern is counting young children on the census. As a matter of fact, young children are undercounted at higher rates than any other age group in the 2010 census. Of course, children can't fill out the forms themselves. They rely on their parents to do it for them. So there's not one reason why children might be missed on the form, but rather there's several situations that might lead a child to not being counted. For example, a child whose parents are divorced might go uncounted if their parents don't discuss whose form the child will be included on. Or a child who's living with their grandparents in a senior living facility might go uncounted out of fear for jeopardizing one's living situation. Getting the funding that's needed to support the families that are struggling is contingent upon a complete census count, which means that we have to overcome the undercount of young children on the census. Young children, again, are the most undercounted group, but they're also the population that potentially have the most to gain from a complete census. Beyond this, the data captured in March 2020 will be the premier data source for the next 10 years, which is most of a childhood. Most of a childhood can be transformed by a complete count. The good news is that we can combat the undercount. CCC has been working closely with partners to raise awareness on this issue through our Every Child Counts NYC campaign. We're going to link to the campaign site at the end of this presentation so you can learn about the undercount, and we encourage you to get involved. Myself and my colleague Carlos Rosales hosted a webinar on the undercount of young children, which can also be found on our YouTube page at CCC New York. Again, we will provide these links in a few moments, and that's also where you will be able to find this webinar today. I'm going to pass it over to Alice to give a real-life example of the threat of an undercount and what it means for communities.
Thanks, Sophia. I think one of the reasons we wanted to sort of include this at the end is it really shows the way that data ties in with health funding, which in turn ties in with health outcomes. So we wanted to provide this real-life example, although it doesn't take place in New York, that illustrates the seriousness of the undercount. So in 2017, the city of Detroit applied for $1.34 million from the CDC to allow them to hire more health department staff, and they'd be focusing on assisting the city's effort to prevent childhood lead poisoning. As critically needed as this funding was, the city was denied because the 2010 census put Detroit's population at just below the grant's 750,000 minimum population requirement. Importantly, only 64% of Detroit households responded to the 2010 census. And while we don't know the exact amount, we know that there was an undercount in the tens of thousands, which likely led the city missing the threshold that was necessary to receive that lead funding. So this is just one very specific example of how an undercount in a census plays out in very real, very detrimental ways in terms of funding allocations. A separate report out of George Washington identified 37 states that may have lost out on millions of dollars in federal funding in fiscal year 2015 if their population was undercounted by 1% in the 2010 census. And we know these kinds of undercounts that have always happened are going to be even worse because we've seen that this federal administration has made a lot of efforts that could even further reduce or really increase the undercount of young children among other populations. So again, as Sophia said, we have been doing a lot of work on this and will continue to do work. And it's a really great way to become engaged and find out if there are specific ways that you can really combat the undercount in New York City and New York State.
So we do want to wrap up and really let you all know how you can stay informed and get involved with the census work among all of our other work. You can feel free to explore the data that's on our website, the data that we poked through today, alongside the wealth of other indicators on keeping track online at our website, data.cccnewyork.org. You can also sign up to join our e-action network, which will give you updates on the stuff that we're doing and send out calls to action for issues that we are working on in our advocacy work at cccnewyork.org/sign up. You should also check out our Every Child Counts NYC campaign. This is the census campaign that we just talked about at cccnewyork.org/everychildcountsnyc. Again, the webinar that we hosted will be on YouTube, as well as we will be posting a bunch of census-related and other content on our social media sites on Facebook, Twitter, Instagram, LinkedIn, and YouTube at CCC New York. And now we just want to open the floor up for any questions that folks might have.
And bear with us a minute. We will, I think everyone is muted right now, but give us a moment and we'll make sure to unmute everyone. And you can also type in questions if you prefer to in the question and answer box. Okay, I think we have successfully unmuted everyone, although there's one participant who it seems like is using an older version of Zoom, and apparently that does not allow us to unmute you, so I'm sorry about that. But I think a few folks on the phone are now unmuted, so no pressure, but if you have any questions, we'd be happy to answer them. Uh-oh, hold on. Let's give this another try over. Well, still having a couple difficulties. Maybe type in, if you are on the line and you're talking now, we can't hear you. So maybe type in a question if you have it. It looks like we're still having some trouble unmuting folks, but it's also possible folks don't have any questions right now. You know what I realized we failed to do on this is to include our email information, but I will just say that out loud right now. My email contact is abuffkin@cccnewyork.org.
My email is a little bit less easy to intuitively spell, so that is shalkitis@cccnewyork.org. You all can feel free to send us any questions that you have there if they're not being addressed here.
So let's give it one more minute in case anyone wants to type questions or ask them, and then we will go ahead and close it down and encourage you to check out our website and reach out to us if you have any follow-up questions. Okay, all right. Well, thank you everyone so much for joining us. We really appreciate it, and we look forward to hearing from you in the future.